Let's move on to the cardiovascular pathology section. This is a very high yield topic on your exam, and it makes up a large proportion of your first aid chapter. Let's begin with congenital heart diseases. Now, when it comes to congenital heart disease, there are basically two important categories to keep in mind. You have your early cyanotic lesions, and then you have your late. But we keep talking about this term cyanosis. So let's discuss a little bit of what cyanosis is and why does it occur. It is because we do not have enough oxygenated hemoglobin, so low oxygenation of hemoglobin. Now, in physical exam, where do you look for signs of low oxygen in the blood, and what would you see? Well, you look at highly vascularized tissues that have a really high velocity or fast blood flow and a very low arteriovenous difference. And this means that there's high oxygen extraction of whatever tissue we're talking about. Remember, fast blood flow through tissue does not give that tissue much time to extract oxygen from the blood. So these tissues have very high velocity, or they have a very high arteriovenous difference to begin with. So what are some highly vascularized tissues that we can talk about to see some signs of cyanosis? Definitely the lips, all mucous membranes in general, and this includes the eye conjunctiva and the nail beds. So blue babies have blue lips, blue mucous membranes, such as the oral cavity, and blue nail beds. And they can definitely have a blue-like coloration of the conjunctiva due to the low oxygen tension of the venous blood within the conjunctival tissue. So the first group is called early because babies born with any type of congenital lesion in this group will immediately show signs of cardiovascular distress, including cyanosis, immediately after birth. The mnemonic for these 5 lesions all starts with a T. So the 5 T's. They are tetralogy of Fallot, transposition of the great vessels, truncus arteriosus, total anomalous pulmonary venous return, and tricuspid atresia. So those are our 5 T's. Any of these 5 lesions will lead to a cyanosis that is immediately recognizable at birth. All of these prevent adequate delivery of oxygenated blood because, number 1, there's either insufficient blood flow into the pulmonary vasculature, or number 2, there's excess blood flow into the lungs, causing an engorgement of the pulmonary vasculature, so that we cannot put enough oxygen in the blood in situation 1 because there's not enough blood flow to the lungs, or 2, there'll be excess blood flow and some of the blood may be circling back into the heart and causing engorgement of the pulmonary vascular bed, and this can lead to pulmonary hypertension. We'll get into this in a second. So number 1, there's essentially decreased perfusion of the lungs. And number 2, there's increased pulmonary blood flow with decreased systemic output. So tetralogy of Fallot and tricuspid atresia fit into the first category. There's just not enough blood reaching the pulmonary vasculature. Tetralogy of Fallot is due to the stenotic infundibular septum. We'll get more into detail on this later. And tricuspid atresia is the fact that you have an atretic or not canalized or not open tricuspid valve, and that causes a hypoplastic right ventricle. Again, we will talk about this more later. D or dextro or right transposition of the great vessels, truncus arteriosus, and totally anomalous pulmonary venous return all fit into number 2 because there is an increased flow of blood into the lungs, but insufficient amount of oxygenated blood is delivered to the systemic circulation. All of these are immediate problems at birth due to the fact that we close our ductus arteriosus, or we begin closing our ductus arteriosus after we take our first breath. The closure of the ductus arteriosus also occurs at the same time that we have a dramatic increase in our pulmonary vasculature vessel diameters, or in other words, we open up those vessels in our pulmonary vasculature when we have increased oxygen tension in our blood from that first breath. This greatly decreases the pulmonary vascular resistance. So obviously this event completely changes blood flow and can cause a neonate to turn into a blue smurf if we disrupt any of these normal events with abnormal anatomy or physiology associated with some of these congenital heart diseases. Let's go through the early cyanotic lesions and then we can discuss the late cyanotic lesions after that. So first one up is the persistent truncus arteriosus. So let's get this thing started. The name here really tells us a lot. We discussed the truncus arteriosus in the embryology section. Let's review the embryology here to make sure that we understand what is going on. So during development, a single truncal root, hence the truncus arteriosus, will later be divided into an ascending aorta and the pulmonary trunk, or the root of the pulmonary artery. And as you can see, there's a septum here that needs to divide this truncus arteriosus to develop these two structures. The septum divides this one vessel and then twists while it's coming down, because its final goal is to fuse with the endocardial cushions and the interventricular septum. Do you guys remember which type of cells are particularly important in this migration and twisting of this septum? The neural crest cells. And that is why we see it in a lot of the syndromes that involve neural crest-derived abnormalities such as DeGeorge. Alright, we know this no problem. Neural crest cells are responsible for this. There is almost always an accompanying ventricular septal defect in this heart disease, because the descending aorticopulmonary septum, which is this septum here, because it is dividing the aortico and pulmonary elements of the truncus arteriosus. So the aorticopulmonary septum that is descending has to come down and fuse with the endocardial cushion that is sitting in the middle of the heart chamber. The endocardial cushion is responsible for fusing with the descending aorticopulmonary septum and closing any potential communications between the right and left sides of the heart. So let's summarize quickly. The septum should form in the middle of the truncus arteriosus to separate it into the pulmonary trunk or pulmonary artery base and the ascending aorta. If this septum fails to migrate down and twist, therefore we did not separate this one vessel and we remain with one continuous vessel. So this one vessel, called the truncus, is persistent and it gives rise to just one trunk instead of the two arteries, the pulmonary trunk and the aorta, that we are interested in. So this means that we did not separate how blood enters the ascending aorta or the pulmonary trunk. In addition to that, the fusion of the endocardial cushion with the aorticopulmonary septum never occurred, and that is why there is now a ventricular septal defect. So let's summarize. What are we left with? We're left with one big vessel, or a persistent truncus arteriosus, just sitting over this unclosed interventricular septum. We will have blood from the right side and the left side pumping into this one huge vessel. There is no separation of the pulmonary and systemic circulation. As you can see here, they both are supplied by the same outflow tracts, the right outflow tract and the left outflow tract. The baby is cyanotic at birth because there is mixing of deoxygenated blood from the right side of the heart with the oxygenated blood from the left side of the heart that is receiving blood from the pulmonary circulation. So do you remember what happens at birth to our pulmonary vasculature? The resistance within the pulmonary vasculature drops significantly. Because we drop our pulmonary vasculature resistance, we'll shunt blood from left to right, because this defect is not large enough to create any sort of pressure difference. The left and the right ventricle will equilibrate, and now we will shunt blood into the low pulmonary vasculature resistance circuit. So as the pulmonary vasculature resistance continues to drop after birth, we get more and more shunting of blood into the lungs because it is a highly parallel circuit and that has a very low resistance. The increased pulmonary hydrostatic pressure, though, that is created from this increased blood flow can lead to difficulty breathing. This will show up as nasal flaring, costal, which means rib, and sternal, which means sternum, retractions, grunting, because they're trying to increase their end expiratory pressure to keep their alveoli open because they're engorged with blood, and obviously an increase in respiratory rate, or tachypnea. Okay, great. We absolutely dominated that. Let's go ahead and move on to detransposition of the great vessels. Let's analyze this disease by just checking out the name. So D is for dextro, which is a fancy way to say right. And transposition means that things are flipped. So in dextro transposition of the great vessels, the origin of the aorta is anterior and to the right of the pulmonary artery origin. We know this is not normal. Usually these are on the opposite sides of each other, as in this image. That is that currently they are transposed to the normal, with dextro indicating that the ascending aorta is on the right side. So this doesn't make any sense at all, right? This is not advantageous, this is not normal. Why? Because after the ascending aorta receives deoxygenated blood from the right ventricle, it is going to send it to the systemic circulation. Well, that is not how the body is designed to work. Now what about the left ventricle? The left ventricle will pump blood into the pulmonary trunk, which means we are sending blood into the lungs from the left ventricle. Basically, we have two independent circuits that are not interacting with each other at all. The right ventricle will send deoxygenated blood into the aorta, into the systemic circulation. It'll go through the body and then back into the right atrium and will repeat within this loop, while the left ventricle will pump blood into the lungs and the blood will return back into the left atrium via the pulmonary veins, and it will continue to this nonsensical loop. So obviously these two are divided. We have to have some sort of way for these two to communicate. What do we need to do here to survive besides fixing the problem, or resetting, or untransposing the great vessels? Well, we need some sort of communication between these two circuits. How can we do that? Well, we know plenty of ways that we can do that. We can mix blood at the level of the atria with an ASD, at the level of the ventricles with a VSD, or at the level of the great vessels with a patent ductus arteriosus. So how did we even get into this situation to begin with? Again, this is neural crest cells. They did not spiral correctly, so the aorticopulmonary septum developed, but it did not spiral. There was none of this, no spiraling. It just went straight down. And when it goes straight down, then you directly connect your ascending aorta to your right ventricle and your pulmonary trunk to your left ventricle, again creating two independently functioning circuits. We need some sort of ASD, VSD, or PDA for allowing some sort of communication between the right and left circuits. The only true answer is that you do surgery to switch these around. Excellent. Let's continue moving on to tricuspid atresia. So this is a quick one we can just draw out. So tresis is actually Greek for perforation. We know that whenever you put an A in front of everything, it means that you have without. So tricuspid atresia is when we are without a perforation that involves the tricuspid area. Tricuspid atresia literally means there is no tricuspid valve. There is no communication formed between the right atrium and the right ventricle. And if it did form, it is very, very small. So let's kind of draw out the four chambers. We have our right atrium, right ventricle, left atrium, left ventricle, and that's normal in a normally functioning heart. In this situation of tricuspid atresia, the right atrium is separated from the right ventricle by a atretic or not well-developed tricuspid valve. So in this situation, the right atrium is very large and there's no communication between the right atrium or the right ventricle. And if there is one, it is very small and does not contribute to any blood flow from the right atrium to the right ventricle. So there's no communication between the right atrium and the right ventricle. That's just the way you need to think about it. The right ventricle will not have any blood delivered to it. It will have no reason to develop into a normal chamber because those chambers need blood to fill them to encourage their development into a normally dilated chamber. This is a common theme in embryology. You need some sort of perfusion fluid pressure within a tube or chamber to recanalize things. So, if we do not have a functional right ventricle, then how are we going to get blood into the lungs? Well, we need an ASD and a VSD. We need an ASD to take deoxygenated blood from the right atrium into the left atrium. And then we need a VSD to shunt blood through the tiny underdeveloped right ventricle and up into the lungs, so we can put some oxygen into the blood. So if there's a VSD, even if the right ventricle is tiny and hypoplastic, a VSD can still be used to enter the pulmonary trunk.